maybe. So I want to talk about urinalysis. And as I mentioned before, if you all didn't remember, as a phlebotomist, your responsibility is not only drawing blood, doing venipunctures, but you will work in a full lab. And all of this is based off working in a full lab. As our guest speaker on Thursday, Miss Carrington, she works in a plasma center. So it's a lot of things that you're being taught that you won't even technically do, right? But remember, I'm gearing you in the direction to make sure that you have the information you need to pass your exam, okay? So as a phlebotomist, you do not collect the urine from me, but you do have to prepare me on how, or instruct me on how to collect the urine, okay? So what it is that, I don't know if you remember, but when we went over point of care testing, when we did our medical terminology section, let me bring that whiteboard back up. So right here in black, you see POCT. Remember, it means point of care testing. It talks about it on page 23 in your book, and it means that any test that is done near or in the presence of the patient, and you get the result back pretty fast, which is basically in 15 minutes or so. For example, and when we stick each other fingers that we were in process of doing today, when you check in for my sugar and put it in the machine, it gives us back our glucose reading in about 5 seconds, really, okay? A pregnancy test. If someone was to take a pregnancy test, it gives the results back in 15 minutes or so, okay? A COVID test, same difference. A stool occult test is basically someone providing a stool sample, and the phlebotomist smears it on a stool card, and it will tell the phlebotomist in 15 minutes or less if blood is in that stool, which the doctor would need to know, okay? All of that is rapid. So a urinalysis, basically, let's just say I checked into the doctor's office because I'm having back pain. I may be having burning upon urination. My urine may look really concentrated, meaning dark, or cloudy, meaning like it literally looks cloudy. So I'm going to the doctor because I'm having issues. So the doctor needs to give me relief. And so where we come in as phlebotomists is that if urinalysis is checked on a requisition, we would actually dip someone's urine in the lab to get the results back within 15 minutes. So the doctor would know if I have a urinary tract infection, okay? It will let the doctor know right then if I have an infection, but you will still need to send the urine off so the laboratory technician to make sure that the blood results that you read from your visual eye is still the same. So real quickly, I'm going to show you an example of a urinalysis is what we're going to do in class. So this is the, if we need to do it 2 by 2, this is what I mean, that everything that I wanted to hands-on demonstrate, I still got to do it because I want you to have an understanding. So some things I can do in small groups. So that's what I'm gonna be working on, ladies, getting it together so we can get a move on. Give me 1 second. Talking about I'm gonna remember this for life. Okay, give me 1 second. So this video is just a little bit over 5 minutes. I'm gonna show this video and lecture through it, and give you the instructions of what you need to tell your patient. You will need to write it down so you can be mindful. I don't have a whiteboard for it because normally we would be in person. So when I give you the instructions on how you're going to talk to your patient to collect the urine sample, I definitely need you to write it down because you will see that information again, okay, on the big test and on my last test whenever it comes into play, when I know it's appropriate enough to send it to y'all. Okay, so I'm going to show this video so you'll have in mind what we will do when we get together. Okay, even if it's not a group, but between us. Okay, so let me share my screen, and this is considered a urinalysis dip. Okay, meaning that you would dip the urine yourself as a phlebotomist. This is a timed test, and I will help you to understand it, but if you have problems deciphering color, you would need to let your coworker phlebotomist do the urine dipstick. You can instruct your patient how to collect his or her urine, but when it comes into play, you see these little urine strips here that's on this napkin, and I have this in class, and we're gonna do it, okay? But this is a urine dip that you do in front of the patient while the patient is there to let the doctor know if the patient has anything wrong with their urine. The reason why is different squares, and it should be 10, because each 10 panel stands for something. As a matter of fact, in your folder, because we were going to be doing this today, you have a paper that says urinalysis report. I hope that you have your stuff with you. If you do, can you take it out? And if you do, can you let me know you have it so I'll know who actually has it to look at it? I may also can share my screen. Do you all have it?
I have it. It's the urinalysis dip report.
Yep, that's it.
Okay.
So as I'm speaking about it, if you don't mind, just keep that by your side, because that is the urinalysis report. So when you were to dip this urine in class, that's your report sheet of the results of what the doctor would see. So that's what we have. I'm just going to see here because I do have it. Give me one moment. Okay, Brianna, thank you.
We got it.
Okay, cool. Okay. I was trying to share my screen for those that may not have it, but for some reason my Outlook is oh my God, if y'all heard my stomach all the way on Zoom. Okay, hold on. All right, so this paper is what you should have. Mine is just kind of already typed with Jane Doe with kind of like a little fake patient. So this is a urinalysis report. Wherever you're hired on, wherever you work, if they dip urine to check for urinary tract infections, they will have their own report sheet. Because as you're reading the strip of the video that I'm about to show, as you're reading that strip, you have to put down what you're reading, and it's a time test. So you have to put down what you read at the 30 seconds, at the 60 seconds. That's why it's important for me to make sure that this time is made up so you could do your own urinalysis, stick. And that's why I'm also just thinking if I do it in certain things in small groups, we can get through it faster and do it multiple times. And then when we get together as a big group, then, that can be, something. So don't worry, I'm going to work on things. So that stick, what we call is a dipstick that I showed you that you see in the video that I'm about to show. You see there's 10 things: specific gravity, pH, leukocytes, nitrate, protein, glucose, ketones, urobinogen, bilirubin, and blood. Of course, you're a phlebotomist. You're not the doctor. You don't have no clue why the doctor is checking for this. But when you go for urinalysis, and next time you go to a lab and then you have to provide a urinalysis, this is what the lab is going to result. And it tells you based off if it's normal or abnormal, and it can let the doctor know if you have a urinary tract infection. So remember, as a patient, I'm in all this pain urinary wise. So instead of collecting my urine and making me wait 2 days, the doctor is going to say, okay, we're going to do a urine dipstick in the lab and we're going to see what's going on with your urine. So I'll know what direction to go. And that's where you as the phlebotomist will come in and give the patient the specimen container and let the patient provide the urine. Then when the patient gives you back the urine, or the urine may be sat in the restroom. If you go to some labs, they'll tell you to leave the urine in like a little window unit type thing, because on the other side, they can open up the door and grab the urine that you put there. Then you will take it and then you will do a urinalysis dip. And that's the video that I'm about to show. Okay. So this urinalysis dip, your eyes is very important. The things that I mentioned, you have to look and examine the urine with your gloves on when you hold that cup. So let's just say, I don't even have a cup here, but a specimen cup that you're gonna see it, when we do the demonstration. But the patient is going to give you the cup. You need to be sure that you have on your gloves. If you see little bit of mucus like slime, I don't mean to be nasty, but you will see things like that. So on your urine report dip, you see where it says date collected, date tested, time collected, and tester initials. But then it has what color is the urine, what appearance does the urine look like, and any additions of the characteristics of the urine, so to speak. So color of the urine, is it colorless? Is it like a pale yellow? Is it a dark yellow? Does it have an amber tint to it? You would mark the best appropriate what you think it is when you look at the urine. Does it have any other appearances to it? Meaning, is it clear? Does it have a little haze to it? Meaning like when you look at the urine, you can't look straight through it because it has particles floating in the urine, okay? Cloudy urine, okay? Just like how you thinking about clouds in the sky, you hold up the urine cup, specimen cup with the urine in there, and you look at the urine, and if it look like it's clouds in the urine, it's a thing. Then you will check cloudy. Okay, same thing. If you see blood in urine, you would note blood. Typically, if someone had blood in their urine, just from my experience, it does mean UTI, that they do have an infection because it's that bad that it has blood in it. But if you can visibly see blood in someone's urine, almost 10 times, 9 times out of 10, it's a female and she's probably on her cycle. So if you see the blood, then you ask the patient, Miss Chopin, are you on your cycle? But if you like me and I go to the doctor and have to provide a urine specimen, I already tell them I'm on my cycle. Is that okay? But not everybody do that. Okay, we all women. I just want to let you know in real life, this is real life things. So you see at the bottom of my screen on my paper, I put patient on menses. I just put cycle in parentheses because menses is the medical terminology name of being on your period or being on your cycle. Do you have to know that for testing purposes? No. It's just that when you start to incline more in the medical field and more being a more experienced phlebotomist, you'll start to see that word menses a lot. And it just means it's another name for a woman's period or being on their cycle. So I put here, patient on her cycle, reasons for visual blood. And then I also put urine has a foul odor because on the appearances or additions that a foul odor is not a choice. And there's a such thing with urine being foul. So what I'm saying is in the additional comments, if there's no other box for you to check and there's some things you want to let the doctor know about the urine, you use that extra comment or note section to write things about the urine because you are the one seeing the urine. So to speak, it's very important because even though you're not a lab technician or a medical lab technician, a urinalysis is pretty simple and you will see a urinalysis all the time. Okay. A urinalysis is almost a routine thing when you work in a full lab. Okay. So I just wanted to explain to you the video that I'm about to show. It instructs you on how to do a urine dipstick. And she explains how to dip it and how to read the stick. And that is what we still have to do in person so you can visually do it yourself. We don't do real urine. I actually do orange juice. And the reason why I do orange juice is because I have fake urine, but my fake urine is normal. Normal is too boring. So I wanted to do something that had a little bit of abnormal to it. And orange juice, it will show that it's protein in it. And also orange juice will show it has glucose in it, which is another name for sugar. So when you look at your 10 panel on your paper of what's the boxes on the stick means, you see it has protein and glucose. So that's why I do orange juice, because you'll see what it looks like, so to speak, to have something abnormal about someone's urine. Okay, so without further ado, let me go ahead and show you this video that's a little under 5 minutes. I mean, a little over 5 minutes. I will explain it, and then I will give you the 4 instructions on how you would instruct me to provide you that sample. Okay, let me know if you have any questions, as always. Give me one moment.
Hello, this is Elena with MedLab Diagnostics doing a quick video on how to use your 11 parameter urine test strips. So your urine test strips test for 11 different parameters, and one of the first things that I want to mention is these test strips, any urine test strips, regardless of the brand actually, will start to go bad once you open the seal. They do start to deteriorate because they're sensitive to temperature and humidity. So what you want to do before you test your strip is when you take out a strip, you want to make sure that the leukocyte pad, which is the very top pad on your strip, is still like a white, a bone white color. So it should look like this. And then that lets you know that your strip is still good. When the strips do start to go bad, the leukocyte pad will tend to turn purple like this. So if you open your can and you take out a strip and the unused strip is purple already like this, then that means that the strips have gone bad, and it's not recommended that you use your strips, because a positive leukocyte result looks just like this. It'll turn a dark purple, and that indicates a UTI. So you could get a false positive if you unknowingly use a strip that has gone bad. So just do a quick quality check when you open your strips, and before you use it, just look at that leukocyte pad and make sure it doesn't look purple like that. Make sure that it looks white like this. These strips will generally last around 60 to 90 days once you open that seal. depending on how well you store them. They could even last a little bit longer if you keep them away from temperature and humidity and store them in a dry, cool place. All right, so now that we have our strip here, we're going to do a test, and then we're going to check our results on the pad against the color chart that's on the bottle. So we have a test solution here. Make sure you get your strip completely inside the liquid and take out any excess liquid. And you take it out and then lay it down on a flat surface.
First thing is first, ladies. I used to show this video in the beginning and didn't catch this because now I talk my way through it and teach my students, you know, in my way. She does not have on gloves, you know, so make sure you have on gloves from the moment you pick up the bottle that she's about to do the results with, from the moment that you dip the urine. So I'm sure you've probably seen that, but just know, always have on gloves, and you're messing with someone's urine. And from the characteristics that I just explained, that urine probably nasty, you know, on most cases. So always have on gloves when you put that stick in that urine cup, okay? I just wanted to say that.
And wait the indicated number of seconds before you read your results.
Just go back here.
And then lay it down on a flat surface and wait the indicated number of seconds before you read your results. And you can already see the color changes starting to take place. So depending on the parameter, different ones take different time.
All right, I hope you guys don't mind if I start and stop, honestly, because I want to be able to let you see what we would do in class. So it's blurry on my end. But right here, when she holds up the bottle, you see the black words. You can kind of see urobilirubin, protein. That's probably pH. This is probably glucose, specific gravity, blah, blah, blah. You see all of those are on your sheet. It may not be in order according to the brand of the bottle she's using, but just remember, in real life, whatever brand of the urine strip bottle that your lab is using, the result paper will be in order. So what she's about to tell you is that you dipped the urine strip in someone's urine, you sat it down on a flat, stable surface, and you can also see that some of the squares, the colors are starting to change from just the one that was unused that's on the side of it. It is a timed urine test. So what she's about to tell you is that underneath, you see this say urobilirubin right here. And on my end is blurry. I don't know if it's blurry on your end because of how I stopped the video, but let's just say if this say 60 seconds, that means you do have, once you dip the urine strip in the urine, you start your timer. We would do it in class. I just need you to grasp it for now. You would dip the urine stick in the urine, lay it down on a flat, stable surface, press start on your timer, or use your Apple Watch or whatever it is that you want to use. And what this means is that at 60 seconds, you would have to read the urobilirubin to see what color it is. Is it normal? Does it have a trace? So that bottle will actually tell you 1+, 2+. So if you look at the urobilirubin on your sheet, you see how it may have like 4 or 5 squares next to it. So basically at 60 seconds, it's almost like you would have to see what color it is. Where it comes into play is you can dip urine maybe one day, all day long, and you will be already experienced. It's the fact of being fast with it and be a multitasker, because a lot of those tests you would probably have to read at 60 seconds. So when I worked in OB-GYN at Kelsey Siebold, that's all I did every day, because pregnant women, for those of you that had babies, every time you went to the doctor's office, you had to provide them a urine sample. This is what they were doing, okay? So I got fast with it. So in person, I will teach you a technique on, because right now you're probably like, well, if I have to read 4 of them at 60 seconds, how I'm gonna do that brand new? I will teach you when we do it, when we do get to the hands-on, for me to just be right over you to do it. But I want you to grasp the concept of a urine stick. Okay, so let me go ahead and let the video play a little more.
On the parameter, different ones take different times to develop. Some of them will develop in 30 seconds, some of them 40, 60. The leukocyte pad is the one that takes the longest. It takes 2 minutes. So you want to wait a full 2 minutes before you read that result. But for the rest of them, it's just a few seconds. So we're going to go ahead and start looking at our results. And you can read these either by comparing your results as the seconds go by, or you can just wait 2 minutes and then read your entire strip all at once. So here we go. We're going to start checking out the results. And what you want to do is you want to compare the color on your strip to the color on this color chart, and just look and see which color on this color chart is the closest match to the color on your strip. So for the leukocyte one, which is at the very top, it looks like it's pretty much still that whitish color, and that indicates a negative result. The same thing for the nitrite. It's still that white color, which indicates a negative result. Urobilinogen is this one, and that's a negative result. And then for the protein, we have this bluish color, which looks like it's all the way back here. That's a very positive protein result. And you'll notice that you won't always get an exact match, but you just go with the color that matches the closest to the one that's on your pad.
I'm gonna stop the video even though it's almost over. What's going through your brain right now? Do you have any questions that, I mean, I'm sure you have questions, but what could be going through your mind about how you read the strip versus on that bottle? Does anyone have any particular question? If you have it, I know someone else have it. No?
No, not really.
Okay, so like I said, I do want you to be familiar with it, but I do have to let you do it, for real. And so what it is that this is a urinalysis dip. I'm having urinary problems. You dip the stick inside the urine, and then you place it flat on the surface, and you would read the bottle like she's reading it. The ones over here to the left, all of those mean negative. So if the color of those pads are like the negative, then that lets you know that that particular glucose, protein, urobilirubin, whatever it is negative. But if it starts to change colors, then you would move the stick and move the bottle and match it up to the color that you see most appropriate on that bottle. So to speak, the bottle of this urine dipstick, that is the result bottle. That's how you look at the results. And this is not fake. This is how it's done in real life. So you will place that strip. You will place that strip and hold the bottle, and then just keep turning it back and forth to place it. So it does take a type of multitask and per your memory. So as you seeing it, check what you see on your paper, and then keep going. My thing is, because it's a timed test, I always start 3 seconds before. So you saw one that says 45 seconds. So at 42 seconds, I'm already looking at the color, because we are human. We are not a machine. So it's almost impossible if 4 different panels you have to read at 45 seconds. Your eyes can't be on all 45. And then what if that urine is really messed up and almost every panel is abnormal? You have to remember what you saw to help the doctor. So that's why when we do it in person, the technique that I said I will, fill you in on, I always start 3 seconds before. That way you'll be in motion on all the other panels. And even if you went 3 seconds over, so let's just say that 120-second leukocyte pad that you have to read, which is basically 2 minutes. If you're already at 2 minutes and 5 seconds, it's okay because it probably took you some time. So in class, I have many strips because I have 2 bottles and they're full. And I let you dip the urine over and over until you get comfortable with new strips, because you're going to feel like, oh, I'm slow. Because everybody, when you dip your first urine, you're going to start off slow. And then the 121, the 2-minute one that you should have read at 120 seconds, if you are already almost at 4 minutes, that's entirely too long. And the reason why it's important to be as close to the time as possible is because the moment you dip that stick in the urine and it's saturated with urine, the longer that it's saturated, it will completely get darker and darker by the minute. So if you read that leukocyte pad that was supposed to be read at least at 120 seconds, no more than 125 seconds, and it's already 4 minutes and you just getting to that pad, it's going to be abnormal because it's the urine been sitting on that pad for so long, if that makes sense, right? So, and in person, you're going to see it because I'm not going to make you throw away your strip immediately. It's going to sit, you're going to read it, and I'm going to tell you, okay, let it sit there. And I already told you that orange juice has protein and glucose. So when you read that at 60 seconds, okay, you read it at 60 seconds, you wrote down what was the result. But let's just say the pad, the strip has been sitting there and it's now 3 minutes. That glucose will be more darker than what it was when you read it at 60 seconds because it's just sitting there. So that's why it's important, because you don't want to read these results extremely late and then mark what you think you see and then let the doctor know that I really have this bad UTI. Okay, so that's the thing about this urinalysis dipstick. It's a time test and you match it up to the color of what's on the bottle, and you just keep checking it on your result sheet as you read the results. And this is called a urinalysis dip. And so it will still go to the lab, and I will show you in person how it goes to the lab. Okay, it still goes to the lab, but the reason why you're reading this right now is because the doctor ordered it, and it's a point of care testing, so you can actually let the doctor know if the patient really do have issues with their urine. So the doctor can probably go ahead and prescribe the most common antibiotic until the urine culture comes back. Remember, when we talked about blood cultures, it's the same thing for urine culture, is that it needs to grow for 24 to 48 hours. Once it grows for 1 to 2 days, the culture, it lets the doctor know what bacteria is really in your urine. Yeah, UTI is general. They'll say, oh, you have a urinary tract infection. Okay, but what is the infection? What bacteria is living in it? So that urine culture will tell the doctor what is the bacteria, and then it'll let the doctor know what antibiotic will work best for you. If he prescribed you an antibiotic and it's on that list that it'll work best for you, then he'll tell you, okay, keep taking your antibiotics. If the antibiotics that he prescribed to you is not on that list once the results come back, then he's going to have the nurse or the medical assistant or whoever in the office call you and say, Ms. Chopin, I know that we prescribed you amoxicillin, but we have to prescribe you microbid in order to clear up your infection. So if you ever had anybody or known anybody to say, the doctor changed my antibiotic, that's because the results probably came back and now it's telling the doctor what antibiotic is going to help to clear your urinary infection. Okay, so all of this is what you're doing. Okay, let me go ahead and just finish the video out.
Okay, and then next we're looking at pH, and again, this pH is very dark. So it looks like the pH is all the way over here by 8.5. Then the next thing here is blood, and that looks like a negative result. Specific gravity looks like it's going to be at around 1. The ascorbate is negative, ketones are negative, bilirubin looks negative, and the glucose looks negative as well. So there you go, you compare your strip to the colors on your bottle, and you just basically go with the result that's the closest color match that you have to the colors that you have on your strip. And that's how you read your results.
Let me just go back to the beginning so you can, see that.
Start to go bad once you open the. So what you want to do is own white color. So it should look like this.
Okay, so kind of just letting you know these strips are untouched. So when you dip it in the urine, it'll start to change. But if any of those pads never did change colors, that's giving you an insight that it's negative. That means it's not showing whatever you're checking for, it's not showing up. And the only reason why you know what each of these squares mean, which one it is because you match it to the bottle. And the bottle tells you how to hold the strip. The bottle tells you at what seconds that strip needs to be read, okay? So it only will make more sense when we do it in person. But this is called a urinalysis dip, and this is what you would do while the patient is in the laboratory so the doctor would know what's going on with that patient's urine. Okay? So I want to tell you, how would you instruct me to collect my urine? Okay, let me get a little cup because I have to be visual. I'm really having a hard time. I'm trying to make it through. Boom, boom. Hold on, y'all. I don't have a little cup, but let's just pretend. This was a specimen. This was a specimen cup, but it wasn't, of course, this big. Let's just say if it was half big, okay? And then also, let's just say we had, give me 1 second. Oh, I got a specimen cup. Hold on. I forgot I have supplies for when I'm on call for home health. Okay, so this is an example of a specimen cup. Urine can go in here, stool can go in here, mucus or saliva can go in here. It's just a specimen cup for non-blood. Okay, remember, chapter 11 is in your book, is the non-blood specimens chapter, but this is a specimen cup. Okay, it is unopened, the seal isn't broken. So when you give your patient whatever specimen cup it is that your lab use, you want to be sure that it hadn't been tampered with, because you don't want to have the urine to be contaminated, so to speak, that you did. Now, urine can come back contaminated, but it can be something the patient did. Okay, so you want to give the urine cup. This is an example of a urine cup. Okay, so right now, this is also a towelette. I don't know if any of you ever in real life provided a urine sample, but if you have, can you just visualize with me as I'm, talking you through this? So remember, I'm having urine problems. I go to the lab. The doctor has ordered a urinalysis, and not only a urinalysis to go to the lab, but a urinalysis dip. On your requisition, if you ever see urinalysis dip, that means that's what you do. On your requisition, if you see urinalysis reflex, urinalysis culture, urinalysis whatever, that's what goes to the lab. Only a urinalysis dip is what you do. So if you see all urinalysis, is not that you're doing them all, you only do the dip, because the dip is letting you know you pick up that bottle with those urine dipsticks in there, and that's what you do. Okay, so I'm your patient, and you say, okay, Ms. Chopin, the doctor has ordered for us to do a urinalysis on you here in the lab. So I need you to provide me with urine. The first thing that I need you to remember, ladies, is to tell the patient, Miss Chopin, I need you to at least give me at least half of a cup full. Some patients don't listen and they may give you back the urine all the way to the top. It is what it is, but it needs to be at least half a cup full. So most specimen cups, let me tell you, most specimen cups, oh, I hope you can see it. This bottle has 90 milliliters. Well, it can fit 90 milliliters of any type of fluid. Do y'all see it? It says 3 ounces, but it says 90 milliliters, right?
Yes, ma'am.
Okay. So this, and in class, my cups are also 90 milliliters. In class, my cups have a blue top, but that doesn't mean anything. It's just different brands that produce these cups. So when I tell you to tell your patient to make sure your patient gives you at least half a cup full, in your textbook in phlebotomy world, as a phlebotomist, you need at least 45 to 50 mLs. So that's why you're going to tell your patient half a cup full. If you give me my cup and say, Miss Chopin, I need you to make sure you give me at least 45 or 50 milliliters of urine, I'm gonna be like, what? I don't even know what that is, right? You need to know for testing purpose, you need at least 45 to 50 mLs of urine. The reason why I'm telling you to just speak to your patient at least half a cup full, because 45 is basically half of 90. Okay, but for your textbook purposes, so that's what I need to make sure. The first thing is first that you write down. Make sure you tell your patient to have the cup at least halfway full. In parentheses, I want you to write 45 to 50 milliliters of urine is what you need. Everyone okay so far? Okay.
Can you repeat that? You said 55 ml?
45 to 50, half of 90. Half of 90 is 45. So you need to know that for your testing purposes, you need 45 to 50 mLs. But when you explain to your patient, you just tell your patient that you need at least half of a cup full, because your patient is not going to know what's 45 to 50 mLs. You may have somebody that's in the medical world, but it's really not, you're talking above people's head if you tell them that. But for textbook purposes, yes, 45 to 50 mLs, that's half of 90. That's why I had you look at the cup. The cup is 90. So half of 90 is 45. Okay. Secondly, this towelette that's here, I need you to instruct your patient that they need to wipe themselves before urinating in the cup. When they wipe themselves, that terminology is called clean catch, because when the urine falls in the cup, the urine needs to be as clean as possible. Did they take a bath? Did they do this? You don't know. But instructing wise, you need to tell them to wipe themselves. Even though you may not feel comfortable, but women need to wipe front to back, not back to front. So for me, I don't care. I mean, I've been saying it, that's how I instruct, tell my patients. I tell them, make sure you wipe yourself from front to back, okay? Males, they just wipe themselves in the circular motion to make sure they cover the whole head of themselves, and they go in the cup. The truth of the matter is that you want to be sure that they want to be sure that they're clean enough, so when this urine falls in this cup, it's as clean as it can be, okay? And it's called a clean catch urine. So you're going to tell your patient, Miss Chopin, I need you to at least give me half a cup full, and I need the urine to be as clean when it's caught in this cup. So I need you to wipe yourself from front to back before you urinate in this cup, okay? It is called clean catch. Okay, I see y'all, Tiana. It is called clean catch. Using this towelette is called collecting the urine by clean catch. Everyone got it? Do you need me to repeat this part by using this towelette to clean themselves? And this is not alcohol. It's not peroxide. It's not Clorox. It's a medical towelette for external use. Has anyone had to provide a urine sample before and was told that you had to wipe yourself?
Yes, ma'am. When I be going to like the urgent care.
Uh-huh. So I hope it makes sense. So instead of being on the patient side of it, you're on the one that's collecting the urine. So if you've ever experienced anything that I'm talking about, I just want you to visualize it and think about it like, oh, I did have to wipe myself when they asked me for a urine. Okay. So that's two important things. 45 to 50 milliliters of urine in this cup at the least. Collect the urine by clean catch, which is using this towelette. Thirdly, I don't want to lose you all, but you need to tell your patient that the urine needs to be collected in midstream. The patient don't know what midstream is, right? So you're going to dummy it down for your patient. And after you tell me to wipe myself from front to back, you're going to tell me, okay, Ms. Chopin, and if all possible, when you start to urinate, you need to urinate a little bit in the commode and then catch the rest of your urine. That's called, in the medical term in phlebotomy, collecting urine while it's in midstream. Any questions with that of midstream?
No, that's exactly what I be doing. Like I do that first and then I get the cup. That's exactly what I be doing. And so they don't be telling me that. I think I just know.
Oh,
exactly, because that's what I be doing. Like I do that first and then I get the cup.
Yeah,
crazy.
So that by the scope of practice, and it's not only for phlebotomists, it's for nurses. When we guide people to collect urine, because what it is that this urine is supposed to be collected in the most cleanest way. Okay. One time I had a patient to give me urine that was full to the top and the urine was almost clear as water. And I believe in working smarter and not harder. So I was like, something is really wrong with this urine. So I went to the patient because why have her come back, and when I know something is wrong. So I asked her, whatever her name was. And I said, your urine is very clear. How did you collect it? Did you do what I instructed you to do? And she was like, well, I had a hard time, so I just dipped the cup in the commode. I think she said toilet. But so when she said that, I said, oh man, I said, this is not going to work. We're going to need another urine sample. Can you go again? And she was like, can I just come back later? I was like, okay. So I knew that something was wrong with it because it didn't even really look like urine for real. Can urine get as clear as possible? Yeah, but it still have a little yellow tint to it, some kind of way. But it was straight, like I knew it was water. And I knew that's what she did because I've ran across people that did that twice. They think you're not going to catch it. So you could be the phlebotomist that don't care and just send it to the lab because you're not going to be the one that probably instruct her again. She probably go to another lab, or you could just go ahead and make it known because why even send it off if you know what I mean? So I said that to say that's why it's appropriate to instruct your patients. Do all phlebotomists do it? No. Tiara or Tiana just told you. They didn't tell her, but she just knew to do it. So the 3 things in instructing your patient how to collect a urine sample, making sure you have 45 to 50 mLs of urine in this cup, making sure the urine is collected clean catch, and that's by using this towelette to wipe themselves from the front to the back. Number 3, make sure the urine is also collected midstream, and that's going a little bit in the commode and then catching it. Can everybody multitask like that? Probably not. I'm almost certain people just gonna pee in the cup, but you have to instruct them to. That way, if the results come back like contaminated or whatever, or it just may be resulted. I can't tell you that if they don't follow them instructions that it can't be resulted, because it probably will. But the scope of practice is that we have to instruct them how to collect it. And that's why you're tested on it nationally on your big exam. Any questions regarding those three things? Did you all write that down?
Yes, ma'am.
Okay.
Yes, ma'am.
This here, you see how the bottle has it automatically comes with the label here. But remember, in labs, in your lab, the label is going to print off already with all the patient's information. And you just have to be sure you put the right label on this bottle that says urine. Okay. But I'm going to ask you though, if I ask you, is it better to put the label on the bottle of the specimen cup? I mean, on the body of the specimen cup? Or is it best to put it on the top of the specimen cup? What you think? Where y'all think the label goes on the specimen container? Rather it's blood, blood.
I think it goes on the body of it.
Okay. Anyone else want to say something?
I mean, I've always just seen that it's placed on top of the label if there is one, and I don't know if that indicates, you know, front up, like how it should be, you know, placed in the container, or I don't know.
What
but
you mean? You
right there in the
always
middle.
saw it, you always saw it being placed here?
Yes.
Well, that's what I mean. Is it placed on the cup part or the top part?
Yeah.
So
The
you
cup.
saying the cup. Okay. Anybody else? What about you, Brianna? Let me see. Brianna, are you there? Okay. Well, so for those of you that answered, you are correct. The label does go on the cup part. Okay. Always be sure the label goes on the cup part, because if you put the label on the top, let's just say if you have other urines there, you took off the top to test my urine. All of a sudden something happened. Somebody started having a seizure or passed out, and you had to stop doing what you were doing. And then when you went back to the urine, then you looked at this cup that the top is off and other urine. Technically, if you label the top and took the top off, the urine is considered like not labeled, and you can confuse yourself with urine. So the scope of practice is always be sure that you have the cup of the specimen cup labeled, not the top. Because the moment you put the label sticker on the top and you take the top off, the urine or the saliva or the stool is no longer labeled. So that's not a good scope of practice, and you're going to be tested on that. Always be sure the label is on the cup, not the top. Make sense?
Yes, ma'am.
Okay. Now, what we would do in person is, after you did your urine dipstick for your patient and read the urine and then alerted the doctor's office of what you read, remember, we still have to send that urine off to the lab. So I will teach you in person how to put your urine in here. And if you can read this, it has a full line, but it also at the top. Do you see where it says urinalysis? Do you see that? Okay. So what it is that this is the same thing of the test that you did to dip the urine, but you still going to send it off to the lab so things can be double checked. But this is the same thing. It's just that it's going to the lab. Okay. You did a urinalysis dipstick, and this is a urinalysis that's going to the lab. Okay. But with the urine, what we'll do in class is you also have to have a urine culture, because if you have an infection in the urine, the doctor still have to know what antibiotic will work best for you and what bacteria it is. So if you can see this correctly it says BD Vacutainer, which all of them do, because remember, that's the brand that makes these things, the company. But underneath it, it says urine CNS preservative. Please don't get this gray top tube confused with your oxalate tube. Oxalate is for blood. This gray tube is for urine. So I want you to be sure you always read the labels on your tubes, because you don't want to put blood in this urine tube and you don't want to put urine in a blood tube, because your brain is saying you're working so fast and you just picked up the wrong gray tube. So be mindful that the urine culture tube also has a little gray stopper. But it says urine for CNS. So we would need to collect a regular urinalysis and a culture of urine, which is why, ladies, you have to have at least half a cup full of urine. So that's why the reason for this urine, okay? That's why you have to have at least half a cup, because when you take this little gadget, it has a needle in there, okay? And this is a little straw. This part goes in the urine, in the cup, and then you take this and you puncture it and it sucks up the urine in there. And that's how you put it in your specimen bag to send it to the lab. This urinalysis top is just a screw on top, so you can pour the urine in there from your cup to the full line. And this is the urinalysis. So this is how urine is transported into a urine tube like this from the cup. Did I lose anyone with that?
No, ma'am.
Okay, so that is considered a urinalysis. So in class, that's exactly what we will do. Urinalysis is in chapter 11. If you have time today, please look at that for me. I'm going to tell you what page is on page 178 and 179. It talks about region strips. That's the name of those strips. No matter what brand, Chelsea can make her own brand of region strips. Tiara and Tiana can have their own separate brands, Brianna, and so forth and so on. Even though we all have different brand of region strips, they're a different brand. But when you take the strip out, it still tests for the same 10 panel, because that's what a urinalysis is, a urinalysis panel. So it's one test, but it have different results in that one urine test. Okay. And as you can see in your book also, on page 179, figure 11.7, it tells you region strips change colors when they react with urine. The color is then compared to a color chart to determine the level of each chemical factor, which is your urobilirubin, your glucose, your blood, okay? That is a urinalysis dip. That is a point of care testing. As you read the strip, you're getting the results of the patient's urine. After you get the result of the patient's urine, you still prepare it to be sent to the big lab to make sure what you saw is what they see under the microscope. You will instruct your patient on how to collect the urine. Make sure the cup, the sterile seal is not broken. Miss Chopin, I need at least half a cup full, which is 45 to 50 mLs. Miss Chopin, I need you to wipe yourself from front to back, which is called clean catch. Miss Chopin, I need you to urinate in the commode and then catch the rest of your urine. That's called midstream. You will be tested on those three. That's 3 questions, really 4 with the label situation. I know we over Zoom, but I really, really do hope that you're paying attention, because when we do meet in person to do it, I'm hoping I don't have to be as detailed and we could just go through the motion with the demonstration. Okay. Any questions regarding urinalysis dip?
No, ma'am.
Can y'all see my screen? Do you see at the very bottom of this quest requisition? On the last, to the right at the bottom, it say UA dipstick only. It say UA dipstick with reflex microscope, UA complete dipstick and microscopic. Do you guys see my screen and see that?
Yes, ma'am. I zoomed it in. We can see it.
And then to the right of it, you see the alphabet that says U. That stands for urine. So that's how you know that's a urine collection. But a UA dipstick only is you're dipping the urine. A UA dipstick with reflex microscopic, that means you dip the urine and you prepare to send it to the lab. Okay? That's what that means. Now, this quest requisition is slightly different from what you have in your folder, but you can still look at the urinalysis and microscopic. If it say microscopic, you don't have a microscope. So that's letting you know you're preparing it to go to the lab. Okay. Someone had a question?
I don't see what you're talking about. I see the urine test, but I don't know what you're reading.
What you mean on the requisition?
Yeah.
To the right, all the way to the bottom. It's the last three.
Oh, okay.
I called on you. You must have left us for a second.
Yeah, sorry. It's because my mom it's a little noisy right here.
Okay. But you see it now, UA?
Yeah.
So that's what I was reading from. So when it says UA dipstick, that means you're dipping the urine. But when you see UA dipstick and microscopic, you're dipping the urine and also preparing it like I just did the example and taking it to the lab. I mean, preparing it to go to the lab. Okay. So make sure you took good notes of what I just said, because just with the urine itself on instructing your patients, that was 4 big pieces of information you needed to know. Okay. And look at your requisition. Okay. And you will see the urinalysis. But when you see microscopic or urine dip for sure means you're going to do it. Okay. And microscopic means it's going to the lab. All right. I just want y'all to, kind of visually see that. Okay. Any questions on the urine? What will all make it make sense is when you do it yourself. But please do me a favor and just be sure you took good notes and you heard me of what I just spoke on. Because when we do it in person, I'm hoping that you don't go all the way back and ask the same everything that I'm taking my time out to explain to you. Okay. All right. Moving forward, I want to go ahead and show you the video for the capillary stick or dermal stick. Capillary is when you prick my finger, you get that little bitty drop of blood. Capillaries is the small blood vessels. That's what lies in our tissue. So if you're chopping onions and you kind of slit yourself with the knife a little bit, or if you fall to the floor and kind of create a wound and you start bleeding, all of that is capillary blood. It's not artery blood or vein blood because you're not sticking anyone to get the blood with a needle, so to speak, in the vein or in the artery. Now, you are sticking someone to stick their finger, but it's not going in any vein or artery. You just sticking the finger. So what I need you to know about capillary punctures is that capillary and dermal means the same thing. If you have a question that say capillary puncture is still sticking the finger or the heel of a baby foot. If it say dermal puncture, it means the same thing. The medical terminology word for skin is dermal. So you may get questions that say dermal puncture, or you may get a question that say capillary puncture. It is the same thing, ladies. Whether you stick in fingers or you stick in the heel of the baby. And that's what I'm going to explain to you. The reason why the babies come into play when it comes to the heel, for babies birth to 12 months, their fingers are too little. You don't stick their fingers, you stick their heel. Okay, and I'm gonna show you images. But on people 1 years old and up, you'll stick their fingers. But what we need to know as phlebotomists is that when we are sticking the fingers, what finger to stick, where about on the finger to stick. Doing a capillary puncture on the finger, it is very easy, really. It takes us nothing but seconds to demonstrate that. We still need to demonstrate that once, you know, I get, you know, things together. You still gonna stick each other finger, or, you know, stick my finger, whatever. But you need to know what fingers are allowed, what fingers are not allowed. And on the fingers that's allowed, where about on my fingers do you stick me? And that's it. Okay. And how to hold the lancet. The lancet is the little bitty needle that sticks us. Okay. So I'm gonna show you this video, and this with Alex, the one that draws out her things, and then I'm gonna talk about it. And then of course it will make sense when you get to do it in real life. If anyone has anyone in their family that's a diabetic, and you may have stick their finger before, or maybe gotten your finger stuck in a lab, try to visualize that again with me, because it's simple in sticking the finger. Okay, so give me a moment, let me prepare that video. It's right under 4 minutes. So before I press start,
hey guys.
Oh, sorry. These things right here that you see on the screen, the yellow and blue, or this purple, pink, and blue, those are called lancets. When you remove the tip of it, it makes it ready for when you place the lancet on the finger and press the button, it sticks your patient, or, you know, you. So that's what we have in class. And just like the picture at the very, very bottom, you see how the person, the lab tech with gloves, is holding the finger and pressing the lancet to get a little drop of blood, which is capillary blood. So this video is going to teach you how to prick someone's finger and what finger and where on the finger to stick. Okay.
This is going to be a quick review on how to place your lance when you are gathering capillary blood from a finger puncture. These are the lancets that you will be most familiar with in lab. Your clinic might have something different. Just whatever lancet you're using, make sure you know how the blade is oriented inside. If you're having issue with this kind specifically, this is a really great video that I'll put a link to in the description. When you choose a finger, you always want to go for the middle or the ring finger. You don't want to go for the pointer finger because the skin is thicker and it's a little bit harder to get that blood going. The thumb is also thicker and it has a pulse, so there's a higher risk for excessive bleeding. And then pinkies have thinner layers of fat and thinner skin, so you have a higher chance of hitting the bone, which can cause an infection. It will definitely cause pain, and in general is going to cause pain even if you don't hit that bone. When you position the lancet, you want to make sure you're putting it in the right area. What you don't want to do is put it in the center. This area is too thick. You don't want to put it on the sides either, because just like the pinky, the fat layer and the skin are thinner, and that gives you a higher chance of hitting the bone or just general pain. An easy way to remember what position you should do is just think of the finger as having a little face. Your eyes are going to be where you can put that lance. You can also think of the tip of the finger having a clock on it, and then your puncture sites are going to be right at the tips of the arms at the 2 and the 10. When you are positioning your lancet, make sure you are going to push that blade in so the blade is running across the ridges of the fingerprint. So if this is the directions of the fingerprint, you want to make sure that the blade is oriented like this, not like this. If you have a cut like this, it's just going to run down those ridges and create a big mess. And it also is not going to give you that drop that you want. Instead, you're just going to have sort of a shallow puddle, and it's going to be really hard to get a sample that does not include skin cells. Instead, you want your cut to look more like this, because then you will build up that nice big drop. And I'll show you what that looks like over here a little bit more. So here's our finger ridges. If we cut like this, it's going to run down the finger like that, and you'll have kind of a shallow, long puddle. Instead, you want to cut perpendicularly, and then you will form this really nice little blood drop that will be much easier to approach with your capillary tube, like that, instead of aiming closer to the skin. Some final reminders: when you're gathering the blood, do not just squeeze the tip of the finger. That's going to cause tissue damage, and the cellular debris, it will get into your sample, and that will affect your tests. You can squeeze the finger in this direction, but it should be light squeezes, and you want to do continuous little squeezes all the way down the tip. Don't like push here, and then push here, and then push here. It should be little tiny pushes coming down. If your patient is not bleeding enough, the first thing you should do is try to wipe away any clots that are forming at the site. Also, use a warm compress. Try to know at the beginning if your patient has cold hands, so you can have that warm compress on hand if needed. Another thing you can do is have the hand in a lower position. I like to have the patient in a chair that is higher than mine, and then have them put their hand on their knee, because that will put the hands below heart level, and they're comfortable and uncomfortable. All right.
All right, let me go a little bit back, okay?
Hitting the bone.
When we start right here, I need you. This is some more important information, and I'm hoping that you'll grasp it for me. When you hold your fingers up, the fingers of choice when you do capillary sticks, no thumbs, no pointer fingers. Even though diabetics, when they're at home and they have their own glucometer, they stick whatever finger they want to. That's fine. But the scope of practice, when you work in a lab, we do not stick thumbs. We do not stick index fingers, pointer fingers, because typically that's an important finger. So we don't stick those. And we don't stick thumbs. Thumbs are too small. I'm sorry, pinkies. We do not stick pinkies. They're too small. We don't stick thumbs, because just like I will speak about in CPR, our thumbs have a pulse. So if you stick through the thumb and kind of hit that pulsating nerve, it can over excessively bleed. So therefore, it leaves only two fingers for us to stick, okay? Which is these two fingers, our third and fourth finger. One, our thumb is one. Our pointer finger is two. Our middle finger is three. Our ring finger is four. Our pinky finger is five. So that's how you count your fingers. I'm sure, most of you knew that, but I want to make sure you know that. So the only fingers that we can stick capillary is the third and fourth finger, okay? No pointer fingers, no pinkies, no thumbs in either or hand, either the fourth finger or the third finger or the fourth finger in either hand, okay? Now that we have the finger of choice, we want to know, okay, where about can we even stick the finger? So when you tell me to hold my finger out, which will be one of the third or fourth fingers, you see right in the area where she has the circle for the most part. Then when we go inside, let me move it a little further. So you see this section here. Where she have the circular motion, that is typically where we will look at. But then when we want to stick the finger, we look at it as a smiley face with the two eyes and the smiley face. The two eyes is where we will stick at. Okay, so to bring back this and where you see the circle, that circle, if you feel your finger and you see that when you point, there's a fatty area, so to speak, a tissue area, that's the cushion part of your fingers. You do not want to stick someone right directly in that cushion part. So you want to stick above it on the side where you see that these eyes are. If you go back and forth from this circle and go back to the eyes, you see those eyes are just right above the circle, so to speak, and they're on the side. So if I put my finger up to you, then you want to stick someone's finger right here and right here, not directly in the cushion part. Okay? Makes sense? Does anyone have a question with that? So you look at it as a clock, you know, so you want to stick a patient either on the 10 o'clock or the 2 o'clock. That's simple. That's it. On the third or fourth digit. So when we do it in person, you'll be able to stick someone right here at the 10 or the 2, not directly in the center, again, not directly in the center of the cushion part of the finger. Any questions just from that? Any questions from what finger to stick, and any questions from where to stick on those fingers?
No, ma'am.
Okay. Now, when we move a little forward, she talks about how to hold the lancet in order to get this, the green that she drew. That's what we wanted. That's what we want. When we place the lancet on the finger, we want the blood to just basically just bubble up as a blood drop. We don't want the blood to just, how can I say it, flow down the finger. So in person, I'm gonna show you how to hold the lancet perpendicular. And perpendicular, if you know, is kind of like side to side like this, not up and down. Okay? But I know you have to visually see that in person because the way the lancets is that I use, you would have to see it. Okay? But at least you'll know what finger you can stick and where on the fingers to stick. Okay? So when you place the lancet on my finger, you want to milk my finger so the blood can actually go to the edge of my finger. Some phlebotomists hold it right here and just press, and then stick it. Well, that's the same thing that has changed with no more pumping the fist, okay? So you want to milk my finger, and when you tell me to give you my hand, when you tell me to give you my hand, you want to have the fingers downward. So therefore, you can milk the finger just in this fashion. And you can kind of see my finger kind of getting a little pinkish tint right there. That means the blood should be ready. Because if you do not milk the finger and you stick me, it's such a little bitty needle. You may stick me and not get nothing because it's such little bitty drop of blood that you need. Okay, so that is the fingers to stick. That is the area to stick. And that is called capillary puncture or dermal puncture. It talks about it in your book on page, give me 1 second. It talks about it in chapter 10, and it gives you step-by-step of someone doing a capillary puncture on page 162 and 163. It has several figures to show you about the capillary puncture, okay? Any questions? I will make more sense again in person, but at least you know the aspects of what finger and about on the finger where to stick. If your patient hands are cold or your baby heel is cold, you have to warm them up. So you may work in the lab and you may have been working there for 2 months already, and you see warm packets or heat packs, and you always wonder what were those for. Well, that's what those are for, to warm up fingertips or warm up heels, because if they're cold, and literally when you stick a patient's finger, you may not, you won't get anything off of cold fingers and cold heels. Okay. Give me 1 second. Let me show you something. Y'all okay? Mm-hmm.
Yes, ma'am.
All right, so this is just an image of lancets that I was talking about for capillary punctures. Lancets come in from different brands, just like everything else. But just to kind of still give you an insight, lancets are used for capillary punctures. They are general lancets. It could be different. They may look different, okay? But they are used for obtaining capillary small samples from a fingertip or heel. That's it. That's the only time you'll use lancets for capillary puncture. And you only do a capillary puncture if it's from the finger or from the heel. Okay, let me show you this. And this is recording, by the way. I kind of forgot. All right, so let's talk about the infant heel. Remember, age birth to 12 months. Do not stick those babies' third and fourth finger. You're going to stick their heel. So in class, if you ever saw that I had a baby hand and a baby foot, I really don't get anyone to draw blood from them. But when I'm talking about capillaries, I kind of show the fingers and the foot because that's an example of what we're doing. Okay. So the areas where it's orange is where you will stick the heel of your baby. So just like on the fingers, and I told you this cushion area of our fingers, you do not stick. You stick at 10 o'clock and you stick at 2 o'clock. Make sure you're not sticking all the way on the side of the finger, because if you feel your fingers, we have bones. Those are the metacarpal bones, okay? So you don't want to stick someone's finger all the way on the side of the finger, but you do want to be at 10 o'clock and 2 o'clock, as the picture says. But you don't want to be right here in the cushion. So same for the heel. You don't want to be in the center of the heel, but instead you want to be in the middle and lateral sides of the heel. If you remember when I talked about positions, lateral, remember lateral means side. Medial means middle. Center means center. So when you're sticking your baby's heel, and some of you, you're probably like, oh my God, am I going to be sticking baby's feet when I get my job? Probably not, but you do need to know for the test. And then eventually you will be, okay? Because you may not even work with babies, right off the bat. But you do need to know capillary punctures on an infant. So if you are tested, and they talk about infant, toddlers, teenager, or adults, they may say, the question may be something like, on a toddler, it's okay to do a capillary puncture in the thumb. Okay, let's talk about it. First, they said toddler. So it tells me, okay, I can stick a toddler's fingers because toddler is over 1. But then they said thumb, and then I can't stick in the thumb. So no, that's not right. So don't let it confuse you by it saying toddler, and you can stick a toddler in the fingers, yes, but you can't stick them in the thumb. So you need to go to the next answer. Infants are heels. Toddlers and up are fingers, but just the same for third and fourth digit. So do not let them confuse you. If they say stick the patient in the pinky, thumb, or pointer finger, that is not the answer. If they say stick the adult in on his or her heel, That is not the answer because you only stick infants in the heel. And you stick infants in the medial lateral side of the heel, right here in this orange area that you see. Because that's where the most of the warmth is. If the baby heel is cold, warm it up. This image says, warm the infant's foot. And 10 times out of 10, babies' heels are always cold. So you probably don't have to warm them up. But just for you to know that if you see an answer that has a choice of warming, be mindful to make sure you read that question in its entirety, because you do know that you may have to warm the infant's heel up, but it's all depending on the answers based how the question was worded. Okay, we still use 70% isopropyl on fingers and heels before using the lancet. Period. We're still using it. Antiseptic technique to be free from germs, to decrease germs. We're still using 70% isopropyl on fingers and heels. We still let it air dry, just like we do when we're doing venipunctures. Puncture the infant's heel, not the infant's finger. What I do want you to write down, you see how it says no longer than 2.0 millimeters. Millimeters mean the depth of your lancet. So I do need you to write down and know that if you're going to stick a baby's heel, make sure you have a lancet that is no more than 2.0, meaning it's not over, because if it's over 2.0 and depth mean how deep it's going to go, you can put the baby in jeopardy by touching their bone a little bit if it's too deep. So you need to be sure that it's no deeper than a 2.0 millimeter, the lancet. So if it says 1.5, like I have in class, or if it say 1.8, like I have in class, because I have two different colors, yeah, you can use those for infants. So what I'm telling you is that when we stick each other, we're using infant size lancets, but you know, it long as it's not over 2.0, that's for infants. For adults, I need you to write down the depth is 3.0 and higher. The reason why it could be 3.5, 3.8, because you may get Mr. Brown, who is a hardworking man, and his fingers are hard already because his hands is hard. If you use a 3.0 exactly that you're supposed to use on adults, and you puncture his finger, you don't see no blood, and he'll tell you, I didn't feel nothing. Well, that's because he probably have to have a deeper lancet. And it can go all the way to 4.0. It's okay to stick a patient more than 2 times with capillary punctures. It's not the same rule as venipunctures with it only being 2 times. Infants, no more than 2.0 millimeters for the depth, the deepness. Adults, 3.0 millimeters and up. Did I lose anyone with that?
So no, you didn't lose me, but I just want to make sure I understand. So you try for the adult, is that 3.0 correct?
3.0 and higher.
And higher. So I try with a 3.0 with, I like the example that you gave with the man with the hard, looks like he has hard fingers, like he works with the hands. And so, okay, I understand going to the next level, I guess. But would you just go to a 5 if you weren't successful with the 3 when you're going again, even though it is okay for you to puncture capillaries more than once? How would you handle that?
Well, the way that the needle depthness go, it don't just jump from 3 to 4 to 5. It's like 3.0, 3.1, 3.2 millimeter. Because millimeter, the measurement of millimeters is small.
Okay.
So yeah, so let's just say
I could be mishearing. So I'm sorry. I thought I heard 5. And so then that was a question that I had.
I mean, there is a such thing as 5, but I've never really I've never known me or anyone to actually use a 5
Okay.
because a 5 is really deep. So, but it can be a 4, but you have, before you even get to 4, you do have other options before you even get to 4.
Okay.
That's why on the baby, it shouldn't be no more than 2.0 because there's 1.5, 1.7, 1.8.
Okay.
So yeah, I hope that answered.
So I just use my judgment and getting, familiar with the lengths of, knowing, all right, well, the 3.0 didn't work. Let me go to maybe 3.2 and then, go from there. Like how to kind of gauge that, or looking at his hand, should I go ahead and start with like a 3.2 if they look hard?
I think that as you get experience, you're gonna know.
Okay.
But based off of what your lab carries, your lab probably for infants, your lab probably only carry 1.6 and 1.8. So therefore, you only really have 2 options to work with anyway.
Okay.
I would always start with the lesser one first, whether it's a baby or an adult.
Okay.
So if it was Mr. Brown to come in, even though he have hard fingers, still start with a 3.0 and then just work your way up. But in your lab, you may not even have 3.0. You may have 3.2 and 3.7. So you have those 2 options only. So to answer that question, start with the lesser one first and work your way up depending on what you have available.
Okay, thank you.
Mm-hmm. So for testing purposes, 2.0 for no more than 2.0 for adults and 3.0 for higher. Sorry. I think I have some kind of action about tomorrow. Just give me 1 second. Okay. Keep your fingers crossed. Okay, any other questions regarding capillary punctures and the difference between adults and children? Good question, Miss Chelsea, though. And but as you get experience, you would know. And let me add, capillary punctures, even though you may not stick any children for time to come, you will be doing finger sticks. You remember Carrington, if you work in a plasma center or a blood bank, that they hands off, they do that automatically. So you will be get used to doing those, because before you can even donate blood or plasma, they do a finger stick to make sure your iron level is where it needs to be. Okay. And you may be the one that's doing finger sticks today on everybody, So it is important for real life aspect of it to be comfortable with doing finger sticks. We will do it in class, and I will give you extra lancets to take home in your take-home kit to stick someone else's finger, but it's really simple, okay? But definitely I'll give you tries, okay? Any questions with the urinalysis that I spoke about, and any questions with the capillary dermal punctures that I spoke about? I did try to emphasize. I mean, I like always, I give you textbook and real life examples, but as far as textbook is concerned, I do emphasize on what I know you're going to see. Okay, so hopefully you took good notes with that. I did kind of say 12 to 2. Have I've lost y'all attention? Do you have about 20 more minutes?
We still here. Yes, ma'am.
Yes, still here.
Oh, thank you. I needed that to laugh. I may need some wine later. God, this day.
I understand that.
Okay, so if you can give me 20 more minutes at least, I want to explain to you the different precautions versus airborne, contact, and droplet. Okay, so therefore, you're using standard precautions right now. But what if you was a phlebotomist inpatient, meaning that you were a phlebotomist in the lab, and you walked up to my room and I had a sign outside my room? That means that whatever was tested, now it came back that I have something that can be contagious. So you need to know the difference between them all. So give me a moment. Let me bring up those posters. Thingies. I know we're on Zoom, so even though we would have normally been together till 3, I don't want to lose your attention. So if I had lost it, that's why I'm like, just let me know. But I just want maybe just 20 more minutes, okay? Give me 1 second. Because even though I know with the urine and the finger sticks, doing the demonstration will make it make sense. But again, I just didn't want this day to go untouched at all. So I hope that you do. Oh, let me type this precautions. And right about now, we would have had lunch. I think my stomach is touching my back. Okay, I'm just trying to laugh.
Mine's too. I'm eating some Pringles. I had to run downstairs, ask my mama, can I have back on, please?
Let's see. That must be why my food is going off. Okay. All right, so let me go ahead and share my screen. Right here is the exact thing that will be on your patient's door. And this is by the CDC. You see at the bottom, U.S. Department of Health and Human Services, Center for Disease Control and Prevention. Remember, the CDC is responsible for finding out what the disease is, where it came from, what the disease is, how to stop it, and how to prevent it. So when it comes to our PPE and the different precautions, that is pretty much told to us from the CDC website. So let's just say that urine dip that we just did, that we talked about. Okay, you did the urine dip and I had some glucose, some protein. It probably showed that I had a little blood when you dipped the pad, not that you saw it, but when you dip the pad, you see one of those choices were blood, right? So when the results was faxed to the doctor, also I want you to know that the most secured way to fax results back, to get results back and forth from the lab to the doctor's office is by fax, not by email, not by hand delivering results, because doctor's offices are all over the city. So the results are always faxed. Okay, if there is critical, if you are not just working in an outpatient lab, but you may be working in the actual big lab and they have you faxing results to the different doctor's offices, if there are any critical lab results, your supervisor will tell you this. You will be orientated towards this. But the phlebotomist will call the doctor's office or page the doctor, depending on if it's a weekend. You will be instructed to do this by your lab. But you will report the critical lab results and then fax it. If it's not critical, you just fax it, and you do not have to get in touch with the doctor's office or the call the on-call number. Now, that's something that you will learn because your lab will train you for that, okay? But let's just say that urine that you dipped for me, it came back with some different things. You sent the results over to the doctor's office. The doctor prescribed me antibiotics, but you also packaged it up like we talked about to send it to the lab. Remember, it takes 24 to 48 hours for culture of any bodily fluid to be ready because it's given the bacteria time to grow. All right, so now let's just say my results came back. The bacteria name is streptococcus or something. You know, them bacteria names, honey, they have some words, some alphabets to them. Okay, so it came back that I had whatever I just said. So that means I need to be placed under contact precautions because if you touch my urine, it can be something of contagion. Okay, but let's just say you didn't touch my urine, but let's just say I went to the restroom, I didn't wipe myself. I'm just being honest. People are out there in this world. And let's just say they touched the doorknob, they touched the bed rail of their hospital bed because they're inpatient. You went in there, okay? That's why these signs will be on the outside of the door. So what it's telling you is that if you see contact precautions, that means that patient in there has something that if you touch, because contact means touching. If you come in contact with that bacteria or germ, it is of contagion, okay? So this sign on the outside of the door states, stop, contact precautions. Everyone must clean their hands, including before entering and when leaving the room. Providers and staff. Remember, provider is another name for doctor, and staff is you, me, whoever else. Providers and staff must also put on gloves before room entry and discard gloves before room exit. Remember, we already gonna put on gloves anyways, but we need to be sure we put on gloves before going in that room because we could touch anything that that patient didn't care about and touched, you know? So anything, contact means anything that you can touch, contact, okay? So we put on gloves and then it say, put on a gown before room entry, discard gown before room entry. Put on gown before room entry, discard gown before room exit, I'm sorry. So when you're inpatient and you see this sign, you're probably like, how am I gonna put on the gloves and stuff before going in the room? So if someone is on precautions, that sign will be up and the PPE will be outside the door of the patient's room. Therefore, you can put all of that on before touching the door to go in my room. Okay. If I am by being a nurse, if I gotta take the vitals, or a CNA, if I gotta take the vitals, doctor, if I gotta listen to the patient's heart, any equipment that I'm gonna use, it has to be disposable. So that's why it says use dedicated or disposable equipment. Clean and disinfect reusable equipment before use to another patient. So try to use this disposable equipment. So I don't know if any of you have been in this situation, but there is disposable stethoscopes and blood pressure cuffs. So therefore, when you take my vitals, that stays in the room for me. So every time every time I come in, that's mine because stethoscopes goes in my ear. It's mine that I use for you. So I may leave it in your room. But if it's a doctor that's only seeing you, you know, once this week, he will use or she will use something of disposal and just throw it away. But what I need you to know is that this person has a contagion of something that you can catch on contact. So you need to know what PPE to put on. So in this case, you're already going to have on gloves. So gown is what you add. Contact precautions. Screenshot this if you haven't already. Any questions regarding contact precautions? Okay, Brianna, I did just see your message. Okay, let me go to the next caution. The next precaution says droplets, okay? Now, what this is that it says stop, okay? They all say the same thing. in such a way, but it's telling you what PPE you need to have on to protect yourself before entering. So droplet precautions, stop. Everyone must clean their hands, including before entering and when leaving the room, for everybody. Then you're gonna also put on gloves. Even though you don't see gloves on this, we know standard precautions, we use gloves all the time, okay? Then it says, make sure their eyes, nose, and mouth are fully covered before room entry. So that means you need on a regular surgical mask and either a face shield or goggles, because you have your eyes protected, and with the mask, you have your nose and mouth protected. Okay, and then it says remove face protection before room exit, because you need to go ahead and dispose of that. Most of the time, ladies, in the hospital, when someone has been placed on precautions, hospitals have a double room type thing, to where you open up the door and it's like a protective room that you go ahead and get suited and booted. Then you open up another door to actually go in the patient's room. You just need to know your patient. So if you see this sign, just protect yourself. If it tells you you need to have on a face shield and there's none provided, don't go in that room, okay? Ask the nurse or somebody on the unit where the face shields, okay? Or you call your supervisor down in the lab and say, okay, Ms. Chopin, Mr. Brown is on precautions. They don't have no face shields up here. What you want me to do? You know, just protect yourself first. Droplet precautions mean, y'all remember when COVID came out, they said we got to be 6 feet apart, you know, wear a mask, okay? At first they were saying wear an N95 mask, but then it was okay for us to wear a surgical mask, okay? Droplet precautions means I may have an infection in my lungs, you know, that's coming from my chest. So therefore, if I cough, if I sneeze, and I have an infection of that sort that's already been deemed, because I probably provided saliva or they probably did a breath test on me while I'm in the lab, and it came back that I had some type of infection in my lungs. So if I cough or sneeze, I need to be put on droplet precautions. And that's why you need to wear a face shield, goggles, and a mask. A face shield or goggles and a mask. What that means, ladies, is that if I cough or sneeze and I have that infection, I cough or sneeze, that air, whatever came out of me, will go at least 6 feet. At least that's what medical research say. And then it'll drop to the ground and die. So that's why they were telling us to be 6 feet apart. Because if you cough or sneeze, some people say breathing. Oh, what happens if they breathe, right? So to be sure, let's just stand 6 feet apart from one another. So if you do cough or sneeze on me and you sick and you're not wearing a mask, then it didn't get all the way to me, because it went 6 feet and the germ just fell to the ground and it died. So that's why they changed it from wearing an N95 mask to just a regular surgical mask. Because once COVID was found out that it was a virus, you know, we catch colds all the time, right? That's a virus also. So it didn't require an N95 mask. It just required a regular surgical mask. But we still have to protect our eyes, because what if we are within their 6 feet? Remember, you're a phlebotomist. So you come into my room and it tells you that I'm on droplet precautions. You better have all that stuff on. Because when you draw my blood, you're basically in my personal space, because you got to be like that to draw my blood, okay? So droplet precautions means someone has an infection and you need to be suited and booted with a face shield to cover your eyes, or goggles to cover your eyes, or a mask. Therefore, if I cough or sneeze and I'm on these precautions, you are protected. Any questions regarding droplet precautions and what is it and what PPE you need? Any questions?
No, ma'am.
Okay. I have one more to go over. Give me a second. This is airborne precautions. I'm going to tell you this is what, and COVID could have been this in the beginning, I don't know, but this is what they were saying COVID was in the beginning. The type of bacteria COVID was carrying was an airborne infection. So if I am your patient and you're coming to my room and you see this sign, it says airborne precautions, stop. Clean their hands, including before entering and when leaving room. Then it says, put on a fit tested N95 or higher level respirator before room entry. Then it says, remove respirator after exiting the room and closing the door. Then it says, door to the room must remain closed, not open. So an example of an airborne infection is tuberculosis. TB, tuberculosis, TB, tuberculosis. What that means is that if your patient has TB and he or she coughs and sneezes, not only is it going to go 6 feet and more, but it's not going to die. Your patient cough or sneeze and it's just living in the air. It's just living, period. So it don't go a certain amount and drop to the floor and die. It stays in the air. Okay. So because of it, you need more than just a surgical mask. You need a fit tested respirator, N95. And when I mean fit tested, don't ever work anywhere in the medical field. And if they don't provide a fit test for you for N95, then you're going to have to go pay for it somewhere. Your doctor's office, Concerta, Concentra, whatever it's called, Nova. Try to get fit tested, because what it is that your job may have small, medium, and large. You put on a medium because it fits you good. When they test you, they're going to make you put on the one of choice that's appropriate that you think in the beginning. For me, I know my size is medium. So let's just say if I put on the large or if I put on the small, okay? When you go to your employee health to get fit tested, they're going to make you put it on and they're going to be behind you and spray something of like a metallic type taste. They'll tell you if you smell it or taste it, that's not the right size for you. So as an example, that can be the airborne infection just floating in the air. And even though you don't smell it or taste the infection, that mask, if it's not fitting you right, then you can put yourself in jeopardy to catch the bacteria because you don't have on the right mask. All because when they fit tested you, that stuff is made for you to smell it or taste it because it's made for it to know it to fit you, you know, to know which mask fits you. Okay, so once you get the right mask to be fitted, then you trust the fact that that's the mask that fits you. And so if you walk into your patient's room that is airborne, you have your right fit, you pick up the right size. Because when you walk in that room and the patient has already been deemed that they have an airborne infection, so put gloves on, you may be a person that may want to put on all PPE. Ain't nothing wrong with that, but you just need to know per these signs what needs to be done. Contact besides gloves, you need to have a gown, because what if you drawing my blood, you have on gloves, but you don't have on a gown and you touching the bed rail, and I probably touched that 1,000 times without washing my hands after I use the restroom. So now you probably have something on your scrubs. That's why you put on the gown. Okay. Droplet precautions, cover your eyes. Somebody can cough or sneeze all in your face and it went in your eyes. Okay. Make sure your mouth and nose is protected. Airborne precautions. We already have on gloves, but the most important thing is an N95 mask, because airborne, you can breathe it in and it can get into your lungs. Okay. Airborne precaution. The germ, cough or sneeze for droplet and airborne if you infect it, so to speak. Droplet, it goes 6 feet, fall to the ground and die. Airborne, you cough or sneeze, it's just floating in the air. So when a patient is put in those type of isolation rooms, once the patient is discharged and labs have been done and they don't have the infection no more, you know, they're supposed to be sanitizing that room, but it's some kind of filtered room that that patient is in when they have TB or something like that. Okay.
So
Any questions? Go ahead.
I don't have questions. I just, you know, this lesson is just bringing back a lot of memories. So, I work for the health department, so I did have to do sites, you know, where we had to, you know, put on the PPE, when we were, especially when we were in the testing phase. But, and I also used to be a PHI for TB, so I did have to do DOT, you know, the TB, test, and, you know, have all of that. But I also had MRSA in 2011 when I came back from
They
school.
locked you up in the room.
And they locked me up in a room, and I was there for months, and I couldn't see my oldest son. I didn't have my youngest son at the time. I couldn't see him for a long time. It was a very, very long battle in like getting over that. So it is important, you know, to have that fit test, you know, so that you can protect yourself, because, and then I had to wear certain stuff too sometimes, depending on whatever. So it's just, yeah, it's just very important to make sure you protect yourself.
And the reason why I'm telling you, I hope that my voice really recollects in your brain sometime, because healthcare has changed. You'll get hired somewhere and they don't even bring you know, you need to be fit tested. You know, it's just that, but they'll bring in patients all the time. You could be just be a mobile phlebotomist, walk into a nursing home. They the worst. They are the worst. I'm telling you. Okay, nursing homes are the worst. You can have infected people all up and through there, COVID all up and through there, you know. So just be mindful to protect yourself. Like I said also in the beginning, COVID has introduced us to a whole nother life. So people probably wear a surgical mask anyway. So they probably wear a surgical mask just like, you know, for standard precautions for gloves. And that's okay. I'm waiting for the CDC to just change masks as a standard precautions, you know. But just like Miss Chelsea said, so, you know, she's been through it herself. And MRSA, that's contact precaution. So it's kind of like if you touch, and people can have an infection of anything, infection in the urine, infection, somebody can have a bad wound that went totally infected. I had a patient who had a C-section. She was a big lady, and the C-section bust open or whatever, you know, and it got infected. And when we did a wound culture, which was a swab of her wound, it went to the lab. It had to stay there for 24 to 48 hours to grow, so it could tell the doctor what the patient had, and she had MRSA. So when we go in her room, I was her nurse for a few days. I had to be suited and booted, but, you know, I still went in there, because when you do get adapted to the medical field, that's going to be a way of life. You know, you just get suited and booted, you know, and go in there. But you just need to know the proper steps. But definitely, if you have to pay for it on your own, get fit tested with the N95. And what's so crazy is when COVID was around, pretty strong, so to speak. Like you know, it's not going anywhere. But when it was around pretty strong, people were wearing N95 masks, but they didn't even know if it was their size. So people were still catching COVID, you know what I mean? The same thing as we got vaccinated and we could have still been transmitting COVID, you know? So I'm very particular, and I think I said that in the beginning on infection control, because when we're in the medical field, you do have to protect yourself. And as a phlebotomist, you are in face front. So for example, by me being a nurse, I'm in face front too, but I could probably work 2 or 3 days without having to deal with no blood or nothing. Well, your job is dealing with bodily fluids all the time. Okay, so will you be tested over those precautions? Yes. So I hope that you were able to screenshot them and see what PPE is needed for what. And I hope that you understand what the actual precautions is. TB is an airborne precaution, okay? Contact precaution, besides gloves, you need to make sure you have on a gown. But any questions regarding anything that was discussed today? I did tell you guys 20 more minutes, and I think that I'm pretty much done. I was just receiving emails and they kind of stopped for a second. So I'm just thinking that was just 20 minutes ago. So on tomorrow, just give me a little time to give you guys a definite answer. I'm hoping that all it will be well, that we can meet for 10 o'clock. And for those that can stay past 1, we can get it done. But just give me some time to update y'all, okay? Any questions?
No, ma'am.
No, ma'am.
No, ma'am.
Okay. Again, I'm so sorry, but I do appreciate you guys being on Zoom. You know, we are still moving and grooving. So before we think about throughout the week or next week, you know, just give me some time to see what's going to happen for tomorrow, okay? And I will definitely update you as soon as I know, okay? But other than that, you all please just, you know, enjoy the rest of your Saturday, and I will be in touch shortly. Okay.
Okay, you enjoy yours as well, Miss Juanita. Don't be stressing yourself out. We want to be okay.
Yeah, it's gonna all work out.
Yeah, and I know it will. I just, you know, it's just one of those things of being human. And you know, but my main thing was y'all. That's why as soon as I knew it, after 10 minutes of me talking with the other businesses, I was like, oh my God, let me just start calling, you know, y'all, because I would have hated for everyone to get there or almost there, and then but anyway, so I appreciate y'all very understanding ladies, and we will get past this. So enjoy the rest of your Saturday. I will do my best. You know, I am businessy, so I'm trying to get organized so I can let you know how we're going to move forward. But other than that, I will be in touch. Thank y'all so much.
Thank
Thank
you.
you.
Bye.
Bye, y'all.